A very good evening to all of you. Myself, Dr. Prateek Garg. So we will discuss about nasopharyngeal carcinoma. As the term itself suggests, it is a cancer of the nasopharynx. So this nasopharyngeal carcinoma, it is very common in the Chinese people or somewhere common in the Japanese also. Why it is there? Firstly, these Chinese having higher genetic susceptibility, and plus some of the environmental factor and their food habits, like they are using or they are eating the salted fish, lots of food product containing the nitrosamine, which is mainly responsible and causative factor for this nasopharyngeal carcinoma. And where in the China it is more common? It's in the southern China, in the Guangdong province. Why I am mentioning this? Because it has been asked previously in the exam. Then Guangdong province is the major area where Chinese people are having maximum rate of the nasopharyngeal carcinoma. If we talk about India, it is more common in northeast region, predominantly of Mongoloid origin. So in the northeast part of the India, it is again common. And what is the causative agent or the virus responsible for the nasopharyngeal carcinoma is Epstein-Barr virus. Again, very important. So nasopharyngeal carcinoma, Epstein-Barr virus is considered as the main causative agent. And if you test for the this Epstein-Barr virus, so if there is an increased immunoglobulin type A for the virus capsid antigen, that is increased IgA VCA. So if there is increased IgA VCA, it is a more sensitive test. If we try to find out what is the more specific, then there will be increased IgA EA. Okay, so again, this is important for the examination point of view, that Epstein-Barr virus is a causative agent, and there are two markers, IgA VCA and IgA EA. EA will be the more specific and VCA will be the more sensitive. And there will be the environmental factor like the smoking of the tobacco, opium, then use of the nitrosamine from the dry salted fish, etc. And it has also been seen that nasopharyngeal carcinoma patients are having some sort of defect at the level of the chromosome 6. Okay, chromosome 6. And this carcinoma arises from the fossa of Rosenmuller. You all know the fossa of Rosenmuller. It is located in the nasopharynx. Let's try to get an idea of the fossa of Rosenmuller. So this is the bigger arrow is my fossa of Rosenmuller, just behind the torus tuberous. That is an torus tuberous is an like the nasopharyngeal end of the eustachian tube. So that is an elevated or the bulge out portion of the eustachian tube in the nasopharynx. So beneath that area is known as fossa of Rosenmuller. And you can see in this diagram also. You can see in this diagram, this is my nasopharyngeal tumor presented at the nasopharynx. So what are the symptoms that this nasopharyngeal tumor may cause? See, the first presentation of this nasopharyngeal tumor in a patient will be the cervical lymphadenopathy. That means there may be the enlargement of the lymph nodes in the upper cervical lesion, and mainly this lymph node will be located in between this angle of the mandible, that is the jaw, and the mastoid process between. So patient will having enlarged lymph node in the area just below the ear, in between the angle of the jaw and the mastoid process. So this will be the first presentation. What can be the other symptom? Glue ear. Because of the blockage of the eustachian tube, the patient may have the glue ear. So okay, and what is the most common histopathological type? It is the squamous cell carcinoma. See, in ENT, the cancer of the buccal mucosa, oral cavity, nasopharynx mostly is of squamous cell carcinoma type. Okay, and this nasopharyngeal carcinoma, patient will present with the cervical lymphadenopathy, and if it's there, we should think that patient is already in the stage 3. Generally in stage 1 and 2, patient are having no symptoms or least symptom, so they don't know if they are going with the nasopharyngeal carcinoma. They will present in the OPD with the complaint of enlarged swelling in the neck. Most common neck lymph node, I already told you, in between the mastoid and the angle of the jaw. Then males are 3 times more common as compared to the female in the nasopharyngeal carcinoma, and the presentation in the age group is bimodal, that is in the early 20s or maybe after 60. Okay, so nasopharyngeal carcinoma has a bimodal presentation. These points have been discussed or asked in the exams like the PGI or AIMS, so try to remember every point. Then this infection or nasopharyngeal carcinoma, they may spread to the parapharyngeal space. And if this carcinoma tissue will goes in the parapharyngeal space, so it may cause Horner syndrome. Why? Because in the parapharyngeal space there is sympathetic trunk, then there are the 8th, 9th, 10th, 11th, 12th cranial nerves. So this may damage or some sort of trauma to these nerves, leading to Horner syndrome. Now, what is a Trotter's triad? See, any nasopharyngeal pathology, obstruction or carcinoma will lead to a condition known as Trotter's triad, and it is formed by firstly the conductive hearing loss because of glue ear. Because in nasopharyngeal pathology, eustachian tube will be blocked, so patient will have conductive hearing loss, and there will be palatal palsy because soft palate forms somewhere lies in the floor area of the nasopharynx, so any tumor will push pressure over this palate, leading to palatal palsy. And then third is the neuralgia in the fifth nerve distribution, that is a trigeminal nerve distribution, leading to facial pain, because trigeminal nerve is a nerve supply, sensory supply of the face, so patient will have neuralgia in the fifth nerve distribution. And these three will constitute the Trotter's triad, again very important, asked 3 to 4 times in the previous papers. What will be the diagnosis? How you can do? If the patient is having enlarged lymph node, we should go for the biopsy of the lymph node. We can do the nasal endoscopy to look at mass in the nasopharynx. And if we suspect some sort of malignancy or something, we can go for the CT scan. So what is the treatment in early stages like stage 1 or 2? We have to advise the patient only radiotherapy, that will be beneficial. If it's in the stage 3 or 4, then concurrent radiotherapy plus chemotherapy is what treatment of the choice. Again, these 2 points have been asked in the exam in the last years, so try to remember that.